So I thought, kind of to start off the morning would be good for us to just have a nice little panel discussion about some of the things that we encounter every day in dry eye clinic. And so in ocular surface disease and taking care of ocular surface disease patients, sometimes just kind of seeing what the experts do with the very common things that we all deal with is really helpful. So no specific case presentation for this panel discussion, but I just wanted to ask the experts, what do you deal with some of the main things that we see? I thought it would be a good idea for us to start off talking about Demodex again. What do we do for eye health? This has come up in other presentations that we've done, but do we care about Demodex anymore? And it seems like we were really passionate about those little suckers, and we had to really annihilate them. But when we see those now, what are our thoughts? I think it's something that we could kind of reevaluate every once in a while to try to figure out what is our approach. What is this thing about hypochlorous acid? What is that thing? And why is it amazing for some people? And in my experience, some people really don't like it. But what do you think about Demodex in general, and how do you approach it now?
You want to start, Scott? I know you started. You were one of the forerunners in publishing and talking about these little guys. So I'm going to let you start, and then, like you wanted, I'll probably disagree with you today more.
Which is awesome. I love it.
Everything is awesome.
No, I think for when we started, it was kind of understanding blepharitis because it was in the wake of the failure of the azocyte for blepharitis trials. And why did they fail? Was there something that was maybe unique or different about blepharitis that we were missing? And that's kind of what spurred the interest in, how is that different from maybe bacterial-related blepharitis, which is kind of what we were all taught was the biggest part of blepharitis, right? Now we're kind of back in that circle, back talking about biofilm, But so for a while we were trying to find correlations between number of mites that were present in individuals, symptoms. Nothing really correlated very well. So we had patients that were overly, infested, I guess is the word that we use, which sounds really kind of gross. But we couldn't find really a good correlation between heavily infested individuals and symptoms, or even specific types of symptoms either. So that was really kind of what started it. Now, I still think that there's a lot that we don't know about the relationship. So should we care? We probably should. I think that it makes sense that if we have an overpopulation of any specific organism, it's probably not healthy for the individual. And as we know, there's also relationships that are maybe downstream from just directly having the mite there. Maybe there's bacteria that are in their gut or whatever that produce, pro-inflammatory things for the lids. So should we care? Yeah, probably we should. I think it's part of lid hygiene and ocular surface, periocular surface management. But that's kind of where we are right now. And we've gotten back around to talking more about biofilm, which is maybe I think it's a little bit more abstract rather than talking about specific organisms. But yeah, I still think we should care. I don't think that the mite specifically is probably the biggest part of it. I think there's other relationships there. And then with respect to hypochlorous acid, I know that there's been a lot of claims. Liz, you even mentioned yesterday talking about hypochlorous acid and direct effect on mites, and that relationship I'm going to strongly disagree with, because we actually did the testing at Minnesota Eye ourselves, looking at hypochlorous acid and mite counts. I did that with students, and then Ahmad, your work followed up with that and kind of echoed my results, and there's no direct democidal effect of hypochlorous acid, but it may change the relationship between that and the other bacteria. So I don't know. That's sort of a summary of what my thoughts are. So go ahead and disagree.
You kind of played Switzerland a little bit, so I don't have as much to disagree with. But yeah, I agree. When we first came out, everyone was like, "Oh my gosh, this is the cause of dry eye and rosacea, and this is the silver bullet." And I think we've all realized that there isn't really never a silver bullet. I do think we've all seen patients where this is the problem. I tend to find it's people that want to itch the lash line, like they are very itchy, if that's the symptom. But you also see it, and it's an overpopulation, and yeah, this just looks like it's not right. I agree, there's something to be said about just hygiene in general. The flora, the bacterial and Demodex flora as a complete package, the environment, if you will, that we need to have a clean environment, and that produces good flora. If things are out of sync, then I think that encourages the opportunity for whatever it is, staph. We've all seen plenty of staph blepharitis and staph keratoconjunctivitis, and Demodex too, and there's probably other pathogens too that we might know as much about. So I think having a good, clean ocular surface and eyelid surface is really important. But I've been underimpressed with saying like Demodex is the problem here. I think there are a few cases, and I think there's a lot of unknowns in regards to what is normal flora, especially in regards to Demodex. Does everyone have them? And just like staph, like we don't tell people like, oh, you have staph living on your lids. Oh my gosh, there's rods and cones, rods and bacilli living on your lids. But when people hear about mites living on their lids, like this is icky and creepy and definitely has a scare tactic, and I don't like to use that as much as others, I think.
So to that end, if somebody's, they have 3 to 4 plus biofilm Demodex, they have no symptoms. To the point that you're making, that some of this is normal, but so if they're completely asymptomatic, what do you guys do in that case? I mean, you just gave us a very good summary of the importance of keeping that lid, healthy and the possible consequences down the road. But again, the patient's completely asymptomatic. Do you tell them they have mites?
Are they really asymptomatic, or do they just have their own perception of normal?
Sure.
That's sort of, a picture can show them 1,000 words, so a quick snap of the lids, and sometimes when it's that 3 to 4 plus, you can even see it like outside the slit lamp, and they talk about crud on their lids, and
so how do you rephrase that by saying, yeah, but have you thought about crud? And then that's when they say, oh yeah, I have symptoms.
I would talk to them about symptoms in the morning. How do their eyelids feel? Do their lid margins ever look red? How do their eyes look? And sort of ask about those questions, because they may just assume that, well, I just have red eyes, and not really.
Right.
And
so they can't associate those two.
Adapt.
Yeah.
I mean, that's the one thing that we talked a little bit about yesterday, and I guess I didn't get into the adaptation part of the neurosensory system yesterday, but there is an adaptation. I mean, we see it with contact lens wearers, certainly, right? And so, maybe the 70-year-old that's like 3 to 4 plus Demodex, back when they were in their 30s and 40s and things were starting to ramp up, maybe they noticed burning and itching and those sorts of symptoms then. But our sensory system tends to downplay stuff that we get exposed to chronically. So asking or saying that they're asymptomatic is probably, it's probably incorrect. So, or either that or they're just not alerted to that in the same way that someone who would be newly exposed to it would be. Does that make sense?
Yeah, absolutely.
Just a few comments to add on. So I have one patient in mind because she's that 3 to 4 plus, and she's pretty asymptomatic, but a magnifying mirror with a light is really helpful. So if they have one at home, they can see it if it's that significant. And it, just like the other conditions we've talked about, its treatment is chronic. So we actually need to take a picture. I think pictures are wonderful. Take a photo, share it with our patients, but explain to them that we're going to have to treat them now, but it's not just a one treatment at all. We do have to treat them again and again and follow up with them as well.
Perhaps an in-office treatment, or at least a suggestion of doing some lid debulking and cleaning, and then showing them what their eyes maybe could feel like if they were clean. That may sort of reset their standard of what their eyes should feel like.
And then what?
Do you know what IPL does to Demodex? I've heard
So-
that it can be.
I think there's some, I don't know if we know the complete story, but I think there's some pretty good evidence. I think Laura Perryman is working on publishing some of this, but I think there's some pretty good evidence that it does decrease their populations. But I don't know if I've read
Is it because of
too
the
much
food
about
source?
that.
Yeah, I think that's a little bit more indirect though, because you're not
Right.
really applying the light source to the lid margin and to the follicles where they're most present. So it's probably an indirect thing, because you're not getting that kind of heating or light energy right at the lash margin. Otherwise, you'd be
Inside.
probably losing lashes, right?
Yeah.
So, so it's probably vascular supply and other alterations to that, that microenvironment that are really having an effect if they do at all.
I've seen images of the smaller Demodex just completely
Brevis?
filling the meibomian gland. I mean, it's like setting up shop in the entire gland.
In the follicle space, not in the meibomian gland.
Yeah,
correct?
there's very little.
In the meibomian.
There's very little evidence actually to support brevis in the meibomian gland, other than isolated reports.
Yeah.
So,
I've been treating patients with IPL for a couple of years now. And just kind of sort of gross examination, I don't see a big difference in at least the evidence of the mites. And so I haven't really been kind of extracting mites and kind of looking at them and trying to count, or even just doing a kind of a count of the mites. But I haven't really seen a big difference on the account of the IPL alone. But we're always doing other things in addition to all the other treatments. We're always doing the lid debridements. But I wonder what you guys what your thoughts are, and kind of like what the devices for kind of doing some of the eyelid debridement at home. Do you think that this is going to sort of be the panacea of biofilm, and we're not going to see it anymore? So there's one device that's fairly new that is marketed for folks to kind of take at home, and so I don't know that my male patients are really gonna really love doing that every day, and I get worried about them kind of poking themselves, but then other male patients do really well with it. We're kind of wimps, so
you're speaking about
we either
lids?
we either like hold it way out far enough so it's
Yeah.
not really doing anything, or we're just jabbing each other with ourselves with it. But anyway, I mean, do you think that that's going to be a sort of one of those things that's going to be a big game changer?
I
Or-
think it'll have an impact. I mean, we were doing lid margin debridement, pretty regularly in clinic. We've been talking about lid hygiene on a regular basis, which for most folks, I think they either do incorrectly or it's less effective than what we would be able to do in the office. So this gives them the opportunity to be able to do kind of repeat treatments at home for pretty minimal cost. So I think that's a benefit to the patient for sure. Whether it's going to be widely adopted and implemented is another story. I mean, there's always dynamics around that. But I think it could have a significant impact, at least on how we manage blepharitis, because it seems to have a better effect, I think, than what we're just every 6 weeks or 3 months in office treatments. I think we'll be able to manage it better at home that way.
I think it's another tool for the toolbox, and I'm always willing to have more options for patients, and I think that's awesome. So I think it's a good option. I know we all have these patients that do require maybe more care to their lids than others, and so I think there's probably some role for these patients that really need ongoing treatment, and they are out there.
Yeah.
Do you think that, I'll take your question in a second. Do you think that just like at-home care with like a Q-tip and the right solution, whatever we're recommending as far as a lid cleanser with, doing like manual scrubbing versus this fancy electric toothbrush type tool, can they be as effective? Just tossing it out to the panel?
And so in my experience, I try not to have patients do that. It's kind of like my dialing back on warm compresses and lid scrubs. In the beginning, I used to tell patients, just take pure tea tree oil, a drop of it, and then take macadamia nut oil, mix it in a 1-to-1 ratio, do your, and I'm like, I shouldn't have done that, sort of, so I'm getting farther and farther, away from kind of the Q-tip stuff, and, patients with floppy eyelids, especially guys, again, they kind of cause probably more microtrauma to the lids and more inflammation, so I try to stay away from doing that. Please stay on the stage. There's there's a millimeter back there. Please pull back up before my heart
Please do not
drops.
go off
Okay.
the back.
All right.
Yeah, don't make my late dramatic entrance make you go off the stage. So, I think we do have to have them do an at-home lid regimen. And the people that are in this audience, I'm sure if I polled the group, no one's going to raise their hand, or very few, and I'm not going to ask the question, who uses baby shampoo, right? So not that many of us are making that recommendation anymore, and I think we have better products out there that do a better job and are really designed for the eye. But if we take the dental model, which most of us are subscribing to, especially with things like microblepharoexfoliation and our in-office treatments every 6 months, then you've got to, brush your teeth at home. And then, whether you're doing that from a mechanical perspective or from a product perspective, I think something's got to be done to maintain the lid hygiene. And the lid hygiene is so essential and still so overlooked by a lot of clinicians. I may have mentioned this because I do say it all the time. My students love the eye. They love the eye so much that they'll tell me about every persistent pupillary membrane. They'll tell me about the optic nerve is slightly, malinserted in this eye. And then I go in there and the patient has blepharitis all over the place. So, we need to talk to our colleagues, just conversationally, and make sure that everyone is looking at the eyes, making sure they look at the lids and that they're closing all the way.
So I've had the new lids, I don't know how long, 5 months. I'm a small practice, but I wanted to say to your point on the men, I think the people that is really, really effective, I found 2 groups that are really, really effective. Some of the others, I told you it's a little bit of a hard sale, but one is anybody who has that seborrheic or Demodex blepharitis, and you can do it closed lid. I have a 76-year-old guy that only his complaint was every morning woke up and all this crud. And I did an in-office treatment, and I saw him back 6 weeks, and I take photos, and I showed him how it was coming back. So I cleaned him again, I cleaned him in the office and sent him home with new lids. And he called in for something, and I thought for sure he wasn't getting along. He was like, oh no, that's just fine. I had a question about my glasses, He's doing fine. I've seen him several times, and he said, I've never felt better. His wife called me, his eyes look so much better. And you just do it closed, they can still get most of it without, when you look at the videos on the site and flipping the lids, I don't do that, and they get really good efficacy. That's one group. The other one is a lot of these people with chronic styes had phenomenal results, and they cheer. And the third one is my gas perm wearers that get a lot of the capping, because they're really good at the lids and have that constant, my gas perm, and I have a scleral lens wearer too that just get the chronic capping of the meibomian glands. And so, the others, I'm still a little bit undecided about, but I don't think the whole men, I haven't found that to be a barrier personally at all.
It's a Minnesota thing. I think men here are just a little, kind of squeamish. Men from Iowa are really tough.
I think one aspect that's underappreciated at this point, though, is moisturizing the lid margin, because we think about the lid margin itself, and it's a junction between the mucous membrane surface, the palpebral conjunctiva, and then the keratinized squamous epithelium of the skin. And when there's overlap there, and we have a lot of patients that show hyperkeratinization of the lid margin, I've actually found pretty good efficacy in terms of patient improvement and improving the health of the lid margin just by moisturizing it. So instead of using detergent agents, like we used to recommend baby shampoo all the time, I completely moved away from that. Less detergent, more, like coconut oily or whatever, those types of things to just try to help with keeping that area a little bit more supple and soft. And I think that helps in terms of patient comfort and also in terms of meibomian gland efficacy as well. So I think that's underappreciated right now.
I agree that line of Mark's, that junction is underappreciated and underutilized, and the importance of that distributing that oil. I always kind of call it the cellophane layer of oil that gets smeared across the aqueous layer every time we blink. So keeping that area clean and happy is really good. I would disagree that moisturizers should go there. I kind of find that unnatural. I am big on moisturizers on the external lids, but behind the lashes, once we get back there, I think we get too close to that water lining effect that we get with makeups, and I think we're all seeing that more. So I don't know if I would say we have a good product for moisturizing that part of the adnexa, in my opinion. I'd like to know what the ladies think about that and what your recommendations are too there.
I think this goes to products like, eyelid makeup removers and makeup products. And there were some questions yesterday, not in the panel sessions, but what we recommend to our patients. And I think we do, I personally talk a lot about my patients about makeup and products because patients are wondering and they're just not given any information. So patients who have severe ocular surface disease, oftentimes they're using completely the wrong products altogether. So if I can change even their mascara, I know it's not answering your question specifically, but if I can change their mascara and I can change how they're removing their makeup and recommending that they remove their makeup and changing their face creams and what the products they're using on their face and around their eyes, I find that helps a lot. And these are in my severe dry eye patients too, my patients with Sjogren's that I see. So just recommending specific products. The Eye Eco products are wonderful. I have brochures that I can hand out to my patients. I'm a fan of all the Blink mascaras, the Zoria products as well. So these are things that really can significantly change the surface. Regarding the coconut oil, I haven't tried that at this point in time, but some patients do well with on their skin, not necessarily their eyes, using.
How is that different than what's at the lid mark?
Yeah, true. Would love others' opinions on the coconut oil.
Any experience with okra products?
I do now.
Yeah, I saw that. Yeah. So yeah, anybody sort of been using the new okra lid?
I've been using it in my clinic. We've been using it with our patients, and we've also been doing the in-office treatment for the last probably 3 months. And, I work in a tertiary dry eye center, so I would say that we see the worst of the worst, but don't envision that they're all Sjogren's patients that are, falling off the cliff. They're not. Some of them are moderate patients that just haven't felt success, so they find us. And a lot of those patients in particular have had really good success. We've had people that have had some sort of kind of dermatitis type reactions prior to the treatment, and that sort of calmed that down. It's been remarkable. I have one patient, we call her, what do we call her? Patient 0. She was our first patient at our clinic when we opened. She's had 2 lipoflows, she's had IPL, she's been on Restasis, she's been on Xiidra. She's done Thermi treatment, which is radiofrequency. She's done Lacrocert. So whatever you can think of, she's done. Autologous serum, Regenerized, all the things, right? The thing that she's liked the most was that. So, and if we can make her happy, she's like our test subject. If we can make Miss So-and-so happy, then something has been really effective. So that's the only thing that she said, I could keep my eyes open for a few days after we did the in-office treatment. So I've done 2 treatments on her now, and she's using it at home as well. And she's one of those pain without stain people. There's probably a neuropathic component to her problem. I mean, we've done Lyrica, we've done all of it. Anything you can imagine. I welcome any suggestions that you might have. But she's really enjoyed that product.
Good, awesome.
Is that anti-inflammatory or is it just soothing?
I don't know that there's any studies. You can ask Peter about that, fam, who's designed it. But we're actually looking at doing some research to really dig deeper into the why people have that experience. But anecdotally, the skin looks better, they feel their dry symptoms decrease, and then we've even had reports of improvements in clarity.
So I know you had a treatment, Pat. What are your thoughts on?
I'm moderate MGD. It felt fantastic to me. And I just did one of their lid wipes this morning. I just went out and bought 6 of them. So it felt really good.
And I guess you've...
Hey, Jake, what'd you think?
Yeah, I found it. I have mild dry eye, and my MGD, and I felt great. I didn't have any stinging, burning. Much more comfortable than any other product like that. but my clinical experience is low. But I felt great.
Question?
I felt myself in the eye about a week ago, and yesterday I was having early, tinnitus, I could feel the pressure, and they said that they had results with abrasions and recurrent erosions, and I did it twice yesterday, and I feel better this morning.
Anybody seen my big fat Greek wedding? Have you? It's like the Windex. I kid you not. It has such utility. And I have no disclosures to offer on behalf of Zocular.
What about Windex?
Yeah, well, I don't know. I might avoid that.
All right, so I wanted to kind of maybe shift gears a little bit. Let's sort of, we're seeing kind of the more common kind of early dry eye patient who's kind of mild to moderate, and they have, you know, some symptoms, kind of a very mild to moderate case, and you're gonna, you know, start them on some things, and then you're gonna have that patient back. What is your number one, you know, sort of guide as to whether your treatment plan is helping that patient? And you can think of any sort of diagnostic or even patient feedback or your clinical, you know, sort of findings at the slit lamp. What is sort of the number one thing that you would say, I'm gonna make this my guiding sort of metric, and then that'll help me first of all understand in my own head, is this patient getting better or not, before I start to counsel the patient.
Is our patient a contact lens wearer?
Aren't they
Let's-
all?
Yeah.
All of yours.
It makes a difference.
Yeah.
The answer.
Yeah, let's
Well,
say
let's-
they are. Yeah, please. Yeah. I
So,
said yeah.
so they
contact lens.
wear what type of contact lens?
Soft.
So they wear
Yeah.
soft contacts.
Right,
and
right.
Are
So
they?
soft contact lens wearer, you know, very diligent with her symptoms, but just kind of, you know, has that end of the day.
Mm-hmm.
My eyes are really tired. I have to take them out. You know, around 7 hours, I really have to take them out. But I can still function. I can still work. And you know, so you've done a couple of things to help the tear film, and then you want to, you know, see that patient back in what, like 6 to 8 weeks or something, to see if what the response to the treatment is. What is the number one thing that you look at to see, like, again, in your own mind? I've done some, you know, how do you evaluate the performance of your treatment plan? Yeah.
Of course, there are like 20 questions that I want to ask my patient, but
Right.
if they are a contact lens wearer, I want to know end of the day comfort. And are they able to wear their contact lenses longer? So say they're in a soft, reusable contact lens, you know, I'm going to switch the solutions. I'll switch them to a daily replacement if possible, if the parameters allow. But the comfortable wearing time is a huge one.
Yeah.
In addition to all the 20 other questions I want to ask them. And then, of course, I want to compare what they're telling me initially and then seeing them back. And I'd probably see them back sooner, depending on what we're doing, perhaps sooner than the 6 weeks.
I think vision consistency is another one. You know, the needing to blink to clear at the computer once that dryness symptom starts to set in. And so if they feel like they have a more normal blink pattern, that's one for me that I feel like makes a difference with my contact lens wearers specifically. And you know, in addition to the comfortable wear time, but you know, just less symptoms at the computer, feeling more functional and more efficient is something that tells me that we're on the right track when it comes to trying to improve dry eye and soft lens wearers.
Mine are all dropouts at that point, generally. I don't have a lot of contact lens wearers in my practice. So we just use survey, you know, either a OSDI or speed. In fact, because we do a lot of research and retrospectively cold data, sometimes we'll do both of them and be able to go back and look. But giving that number to a feeling is really essential. It takes the rest of your day out of the answers that you give, and I think that's really important. It's also encouraging it for patients when you see, oh, your speed was a 23 and now you're an 18. Some of our patients, because of the, you know, depression comorbidities that we see, they can really need to have that encouragement, even though they may not feel a huge amount of improvement. You know, I like to see signs improve, we all do, but the symptoms are what bring patients into your office. That's why they come. They come because they don't feel good, don't see well, their eyes are red. They don't come because I suspect that I have SPK. I suspect that my tear breakup time is low. We have a couple of those, but not many. Most of them come because they don't feel good. So, you know, symptomatology improvement is important and being able to encourage them.
I agree. I like all the data, and I feel like it makes me a better clinician to have testing and exam findings and inflammation and osmolarity and all these things. And I agree that surveys can be a great thing, especially for these patients with other mental and anxiety issues alongside there. One thing that I found very helpful in my clinic is we get this 2-page, you get these patients, Whitney, where they come in for their dry consult and there's a 2-page chief complaint. And it's my eyes burn when I do this and this, and when I wake up in the morning it's like this, in the afternoon it's like this, and in the evening it's like this. I kind of, you have to take all of that in and dilute it and run it through the mill. But what I like to do when I sit back and I'm done listening to the patient is say, okay, if I could fix one thing about your eyes, what would it be? And that's something I put in the chart, whether it's burning, sandy gritty is a common one that people say, and then I put that in the chart, like big, fix will be decreasing sandy gritty. Big complaint is I want to be able to wear my contacts 8 hours. Or my work day. That's our goal.
Right.
And if I can knock that down, then I feel like we've been successful.
Yeah.
And that's what we'll do. So first thing I'll come in and I'll read their 1.5-page chief complaint at their follow-up, and then I'll say, that's awesome, how's the sandy gritty?
Right. That's perfect. Yep.
Yeah. I actually, I'm going to agree with you, Jake, despite how you started this morning. But I actually do that on all of my evals as well. I mean, we list the very first thing is primary symptom. What is the thing that bothers you the most about your eyes? And then also following up that with that 0 to 10, like how bad is it, and a lot more descriptive factors. But taking that one aspect of it, I think is really helpful. Mm-hmm. And I couldn't tell you how my eyes felt yesterday. So having the data to support with questionnaires, and I give patients, I think we give them 4 now, because we're collecting all of that stuff. Mm-hmm. They have multiple ways of describing it and quantifying it, and that way we can go back, because I don't expect them to remember when I see them in 6 weeks how, are your eyes better or worse? They won't remember. I don't expect them to do that. But if we have quantifiable number that's associated with how they were feeling at that time, and they could regrade it, then we have a much better idea. And there's definitely patients, Whitney, you're not the only one that sees those interesting psychiatric patients for sure. But yeah, I mean, they definitely appreciate the encouragement. And sometimes it's a little discouraging because everyone goes up and down a little bit, but just having them keep the big picture in mind, and yes, we're making some progress, and this is what was bothering you at this level the last time. I think that's really helpful.
Mm-hmm. Awesome. And the reason I asked too, because I had an experience with a patient I've been seeing for many, many years, and I realized after seeing that patient the importance of getting it clear in my head. Am I getting this patient better or not? And then when I give that feedback to the patient, they really sometimes will go from being in the dumps about how they feel overall to all of a sudden they're elevated, their mood is really elevated if they have that feedback from me, and then using that number 1 chief complaint and making that our combined goal and pointing out that main thing is getting better has really been a productive thing for getting patients on the same page. So perfect. Yeah.
I have a question to the group. So we know that tired eyes is a big symptom in contact lens wearers who have ocular surface disease and dry eyes. So when you're quantifying the tired eyes, and sometimes they're systemically tired as well, and they come back and they say, maybe they just say the number is exactly the same, how do you address that patient?
Sometimes tired eyes, I'm going to just jump in here. I saw what was happening, but I'm jumping over you. So sometimes tired eyes it's a hard one because it's such a broad complaint. It could be contact lens related, it could be dry related, it could be just general fatigue. It could even be something called trigeminal dysphoria, which means the eyes aren't perfectly aligned. And there's some overlap with that. And I've worked with a company in which called NeuroLens, who's used contoured prism in those patients. And their survey, if you look at their survey, it looks at asthenopia complaints as well as dry complaints. And sometimes we might be kind of going down the wrong path with thinking it's a dry complaint when it may be something entirely different.
Yeah, I agree. That is on my list of rule-out things, so I'm glad you brought that up, especially with fatigue. I don't see a whole lot of contact lens patients at this point, but that chronic fatigue, I think, to me, just is a signal that they're not just their visual system, but their entire kind of ocular system is probably stressed for one reason or another. So if we can rule out some of the ocular surface stuff, then what's left over, and if really what they're experiencing is more fatigue related, I think looking really carefully at their binocular system is really helpful.
I found that for sometimes those patients that are fatigued as well, that's one thing that makes me start to think about maybe like a blue light blocking type lens technology, whether it's in, most of the time in spectacles, of course, but sometimes that's when I'll introduce it when it seems that things are improving other than the fact that these eyes are still tired, and or like an anti-fatigue type computer spectacle to help reduce the strain, and a lot of the times that helps improve their dry eye, their perception of their dry eye as well. And so, as you mentioned, aligning the binocular system and getting, sort of taking the load off of that can improve their ability to wear their contacts, the way their eyes feel at the end of the day, just their symptoms in general.
It'll be interesting with the AccuView Oasis with transitions once we all get more experience how that plays into this tired eyes by reducing glare and light.
All right. So let's shift gears one more time. I just wanted to kind of learn from you guys, if you could kind of briefly summarize your favorite ocular surface disease case. Why it's your favorite? What did you learn from it? I know there's so many. It's like
from last week.
But from last week, yeah.
Oh.
Yeah, I mean, the one that comes to mind for me, that really shifted my approach towards the whole symptom and understanding the neurosensory part, was a woman that presented after seeing, I think she saw probably 6 or 7 different eye docs. She'd been complaining about dryness and a lot of discomfort. Primary burning was her symptom. I was still at Minnesota Eye actually when all of this happened, but the one thing that she had that was going on systemically that was potentially associated with it was something called burning mouth syndrome, which I had no experience with at all at that time, and didn't really think anything about it. I guess the long and the short of it is she actually responded extremely well to autologous serum, but in learning a little bit more about what burning mouth is, it's a nociceptor disease that affects the mouth and the tongue, and it creates that constant sensation of burning. So again, it's a different type of neurosensory or neuropathic type of dysfunction, but that completely changed the way that I approached it, because everything that we were doing with her, she had mild symptoms and mild signs of dry eye, but it wasn't correlating well with what I was seeing. So that probably to me was the thing that shifted my approach to dry eye the most, I think, and that was probably about 3 or 4 years ago that I saw her.
I have a good one. It was pretty rewarding. So a patient was referred to me from another optometrist, which I would love to see that, for severe dry eye in her left eye greater than her right. And she had pretty severe dry eye with filaments. And we treated her very aggressively and steroids and tapered her down. But the biggest thing with her is I referred her to her primary and a rheumatologist for a Sjogren's workup. And of course it was positive, but she was also diagnosed with lymphoma because of the diagnosis of her dry eye and associated systemic treatments. And she's been treated for her lymphoma and is doing great. I've been seeing her for several years now, and she's doing very well, and her dry eye is treated very well with, I would call it, mild to moderate immunomodulation, and she's doing really great. So we can make a big difference in these patients' lives, not only for their vision in their eyes and saving her vision, but also their systemic health as well.
Cool.
Debbie Downer, too much?
Yeah, that's a tough one. When it comes to ocular surface disease, I think, my practice, obviously, it's going to involve a scleral contact lens and, changing quality of life. But this one would be a gentleman that it was in, 2013, maybe. He had zoster, ended up with zoster keratitis, neurotrophic epithelium afterwards, just non-healing. We tried everything. He was seeing an ophthalmologist most of the time. This is when I was with Jason Jedlicka still in my practice, and so the two of us were seeing patients every day, and we were at the end of our rope, and that was the first time that we actually threw a scleral lens on, and he wore it 24/7, but he came in like every day for the first couple days to make sure that he was doing better. And even the very next day, walking in, he was getting to the point where when we'd ask him, can you read the chart, please, so we can take your visual acuity after he'd come in, and he'd be like, why should I even read the chart? You guys know I can't see this. So frustrated. And so that's when we decided, okay, we're at the end of our rope here. His cornea is totally fried. Let's put a scleral lens on overnight and just see what happens. So he comes back the next day, and he said that was the first time that he'd had relief. His vision was still terrible, but first time that he'd had any sort of pain relief in weeks, maybe even months at this point. And so we started off with him coming in every day, and then we extended it to every other day, and then eventually we ended up teaching him how to put the lens in and out himself so that he could clean it at home. And he wore it 24 hours a day, taking it out once or twice a day to clean it for probably a month or more. And then now he no longer has to use the scleral lens unless he starts to feel that his eye's getting a little bit irritated. Then he'll wear it during the daytime to give him that protection. But to see him come back just after one night of that protection, that was really fulfilling. And this was at the time when maybe, amniotic membranes were still coming about. And, I've been challenged on this case before as to why we didn't put an amniotic membrane on versus a scleral lens. But he could see through the lens. He had average, once he started to heal a little bit, he could see, he could see through the lens rather than using an amniotic membrane, which would blur him. And that was just a really, that's a case that sticks with me when it comes to really taking somebody out of the dark side and bringing them back into a healthy quality of life.
All these miracle stories, it's hard to follow them.
Yeah. What's your miracle,
Yeah,
Whitney?
I mean, it's hard with Jake and cancer. But really mine, I can give a case, but largely several cases come down to the same point that I'm going to make. I have a patient who comes in and she's got severe rosacea, she's got MGD, a ton of SPK, vision is poor, comfort is terrible. And we talk to her we do the diagnostic testing that we do, and I talk to her about different options, and we get her on a treatment regimen. And this is not miraculous. This is not anything in line with what you've done. But, as I'm talking to her, I said, this is what we're going to do, and this is what we're going to do to help you. And, she just still looked so tense. And I said, so what else is going on in your life? I just opened that question. That can go a lot of different ways, can it, ladies and gentlemen? And I said, so what else is going on in your life? And she said, well, I'm living with my mom now, and my aunt is there too, and she has cancer, and we're trying to take care of her, and it's really hard, and I don't have a great relationship with my mom. And then she just started crying. And, I said, Miss So-and-so, I said, are you a hugger? And she said, I am. And I said, let me give you a hug. And I've done that more than once because a lot of my patients come in burdened by their lives. And all we ask them about is their eyes. And that's what our job is, right? We're not there to be psychiatrists or psychologists. We're not there even to be their friends. We're there to be professional. But sometimes what we deal with is a manifestation of the greater part of their life. So after that, she's come back many times, and she's seeing progress with the ocular rosacea, the MGD. But more importantly, she sees me as someone she can trust, someone she can reach out to. And, I think a lot of us are reluctant to develop a relationship with that patient where we really open up to them because we're afraid, oh my gosh, they're just going to latch on. They're never going to let us go. Most people are respectful of that, and I don't get that. Nobody's calling me at home. Nobody's emailing me and things like that. And I've had that happen, like I said, more than once, and that's what makes dry eye so special to me, is that kind of help that you can give them.
Awesome. All right.
I think you trumped the cancer.
Did I? All right. That was really my goal. I made all that up. No, I'm kidding.
So I can't decide between two groups of patients, so can I show them both?
Yes, please.
Okay. So one are my Sjogren's patients, and I can't even do one case. I mean, I've seen so many people, either I've sent them out for testing, diagnosed with Sjogren's, rheumatoid arthritis, lupus, combination. But these patients have oftentimes seen so many doctors before they get to me. No one has ever heard of Sjogren's. No one does anything about it for their eyes, treat them with artificial tears or something. And this whole group of patients, really getting them on multiple therapies, and then they come back, and even one I saw on Thursday, I saw her urgently because she had to get in March for her insurance, and I just sat back at the end and I said, you look so great. I remember the day you came in. She came in years ago, and I said, you look so great. I remember when you came in, you couldn't open your eyes, you couldn't see, you couldn't function, and she said, my eyes feel so much better, and I feel so much better. So that's like the whole Sjogren's group, and I love caring for these patients and providing them options which can really positively change their lives. And then, of course, the whole scleral lens group. And one patient kind of comes in mind right now. She's been at Grand Rounds. She has seen every service, including neuro-ophthalmology. And she has advanced glaucoma. Of course, that patient, she has everything, right? And so I fit her with scleral lenses years ago. She does have filtering blebs. And suddenly, one bleb just expanded greatly, and she couldn't wear her scleral lens. So about a year ago, we got iPrint Pro and impression-based scleral lens technology. And so fit her with iPrint Pro. So she notices tremendous improvement in her symptoms and her vision, although her vision is quite poor. But subjectively, she thinks this is just absolutely life-changing. And I'm just thinking in my head of my Stephen Johnson, my GVHD patients, and not only with impression-based scleral lens technology, just scleral lenses in general, where you see them and they might not have great vision, but symptomatically, the scleral lenses completely make them so much better. That was a tough one.
So the change in the bleb, was it related to the initial scleral lens? Or?
So when she removed when she removed the lens, she completely affected her bleb. So her bleb expanded. So the glaucoma surgeons were not, they weren't worried about that. They said that's fine. However, she could not wear her scleral lens. And so then when we got iPrint Pro, so the impression-based technology, then it could cover that bleb. Since then, she actually had a bleb revision because her bleb expanded again, and I saw her pretty recently to do another impression. So she should do well now.
Yeah, awesome, fantastic. Good. All right.
What about yours? We gotta hear yours.
Yeah.
So I'm not really a hugger with patients, but
but yeah, I think there's just so many, because it's a really fine line. All of us here, we're very passionate about taking care of our patients, and we want to do everything we can to get them better. And I think that I have made the mistake before of let's be really good
Well,
friends.
I asked.
Yeah. So, but yeah. But sometimes that can really backfire. So you have to
Have you been burned? I'm
you
smelling the
have to be-
burn.
You have
There's
to
a
be
fire over
I
here.
careful.
feel like
Just-
there's
just
a
with
personal story here.
Just the level. So sometimes there's a lot of out of clinic time that it takes to really be methodical and answer every question. If you really care, if somebody gets a hold of your email and then there's 30 questions after you've spent an hour in clinic, it's tough. It's tough, even though you want to do the right thing and answer all the questions.
I only give them my
but-
text email.
Yeah.
Yeah.
So, but yeah, I mean, I think there's just loads and loads of when you do something that at the end of the day has helped that patient, I think it's a pretty powerful thing. So, and sometimes it happens. So there's one case where that information came to me after I saw the patient. I thought it was just kind of some usual day, and I saw a patient and walked out and getting ready to see the other patient, and then my scribe at the time came to me and said, "So did you know that about Roger?" And I'm like, "I don't know what you're talking about." And then she said, well, he was, yeah, he didn't maybe want to say that when you were in the room, but he was very depressed about what was, the level of discomfort on his eyes, that he really thought he was going to harm himself. And so you never really know. And so it was really kind of like, oh, you really, sometimes you don't know the impact of what you're doing. You're just kind of being methodical and going on your, throughout your day, but being very, very diligent, reading all of the, pertinent clinical studies, learning from experts. All of these things really have, kind of a role in what we do. So that's kind of my little story. But yeah.
I think that's a great tip too. That if we sometimes, and I would agree, maybe don't recognize the impact this has on patients' well-being mentally. And there's a fair amount of studies on this too with ocular surface disease, and I could be better at saying, do you need to talk to someone more about this? It's not my wheelhouse. I can send you out east and have you hug a doctor I know, really, but
down south.
I know a hugger.
Down south.
Yeah.
down south where they have sweet tea, right?
Yeah, that's right. That's what we call it. So yeah, to your point, this is a little bit different, a case that comes to my mind. I had a 21-year-old gentleman who, before he came into the office to see me, had connected with my technician. My technician spent, all told, probably an hour talking to him in different increments about his case. So he came in and he, just to sort of set the scene, he's a little bit overweight. He came in a t-shirt and sweatpants or sweat shorts. He doesn't work outside of the home, and he's living with his folks. He came in the pocket of his gym shorts was $1,000 for me to do LipiFlow on him. And he said, I want you to do LipiFlow. That's all he wanted. He said, I've done research on it. I want you to do LipiFlow. My eyes are so dry. And I said, pump the brakes. Let's take a look. We did our whole diagnostic deal. And there was nothing there, nothing to speak of. He had great glands. He had great secretions. His tear breakup time was essentially normal. Osmolarity was normal, on and on. I couldn't find a single motivating factor to do LipiFlow on him. So I said to him, Mr. Jones, I just don't have the clinical evidence to support that. Let's try something, a little bit more basic to start with, a little bit more traditional. And he was really unhappy with that idea, but he said, okay, fine. I said, just give me a month. Let's just see what happens. Give me a month. So I started him on maybe lifitegrast and tears and Brudermass, something along those lines. So he comes back to me 2 weeks later, not a month, and this is after he's called my tech twice. And he comes in and said, I really want to do the LipiFlow now. And I said, well, let's just talk about what's been going on with you in the last couple weeks, too. And he said, well, he went to the ER for his eyes. And I said, really? Tell me why you went to the ER for his eyes. And he said, well, I had a lash that's turned in. Remember how you told me one of the lashes was turned in? So I went to the ER for them to remove it. He said, can you look at my lashes? I'm really worried about my lashes. And went on and on. And at one point I said, I didn't ask him if he needed a hug, by the way. I said, have you had any psychiatric problems? And his mom's sitting in the room at this point. And I said, have you had any problems with this before? And she didn't say anything, and she didn't look at me. And he said, well, I used to take, he took an SSRI, and he said, but I stopped that because I felt like it was impeding my life and it was dulling my senses, so I stopped. And he had all of these sort of OCD, hypochondria kind of somatizations of eye problems that were not really there. And I told him, I said, I can do things for you, but we're never going to move the needle. I said, you need to seek psychiatric help for what's happening with you. Yeah. I said, I believe you feel it. I believe you feel it, but I can't make it feel different. So he wound up going to see a psychiatrist.
I think that you hit the nail right on the head by saying, I believe you, because some of these same folks have seen a bunch of other doctors that have said something else, and that can just drive their condition to even worse.
Right.
Yeah. Fantastic. So those are some of the things I really had in mind. I wanted to ask you guys all out here if this is your opportunity to ask any burning questions that you have for our awesome speakers here in the next few minutes. Anybody else have some questions for them? Scott?
Yeah. You brought up yesterday, I think, a little bit about the mild to moderate evolving ocular surface disease patient without symptoms whatsoever. And it sounded like it's a very good idea to get out in front of it to try to stop this person from becoming more severe. Just how would you word your approach to this person who says, really, I'm just fine?
So my approach is I kind of think about the categories of dry eye, like the ITF or DEWS categories, and I think I draw kind of a line right at stage 2 on our continuum of 1 to 4. And I think if in my own mind, if that patient is right at stage 2 dry eye, and I think that they're at risk of getting into those those other sort of next more severe buckets, I owe it to them to at least talk about it. And then I kind of leave it up to them, and then we decide what to do next. If I give them my case. I say, here's the clinical evidence that you have inflammation that is apparent to me, or maybe not really obvious early stages of inflammation, like non-obvious meibomian gland dysfunction or non-apparent inflammation on the ocular surface. And if I see that their tear film is gone right after they blink, I think those are things that are at least worth sort of talking about. And if the patient just says, again, I'm just fine, I have 0 symptoms, then I just make a note of that, and then I have them back again on their kind of usual kind of 6 to 9 months or something after that, then kind of revisit it, flagging that as somebody that I felt like might maybe benefit from an immunomodulator and kind of and fish oil and things like that. But I think kind of having them help form kind of the treatment plan or come up with the final treatment plan has a big impact on the long-term outcome and the relationship with those patients. So that's kind of how I kind of think about, kind of making sure I have an idea in my own head, and then we kind of come up to, the final decision together. That would help answer your question at all?
Yeah, I would agree. You got to get it out there and address it and let them know it's there. I think we've all seen too many messes where it's not discussed, and then there's some trigger, whether it be glaucoma, which we're going to talk about later, cataract surgery, LASIK. And then all of a sudden there's that push from that stage 1 where I can deal with, like Eric was talking about yesterday, into this, what happened, why you did this, or somebody else did this, and now I'm here. Well, no, we talked about this before, and getting that, being the hero versus being the scapegoat is huge. So I think that it's very appropriate, what Ahmad said, to get it out there and discuss it and say, yeah, you might be doing fine now, but if there's something wrong, you know where to find me.
And visual fluctuation is my favorite symptom, so I tend to focus on that. So even if they have no symptoms at all, I focus really hard and I ask them a million questions about their vision and vision using devices and computers and reading and driving, and do they need to blink to see, and does their vision change? And usually I can get something out of their vision. Now, if you don't get anything, I'm still going to talk to them. I'm still going to start them on treatment, and then I'll see them back. And I'll look at the notes from the original notes and then the follow-up notes, and then ask all the same questions, and most of the time they've noticed improvement. And then I love it even years later. Well, I didn't have dry eyes. However, this, and this is better. Okay, great. Good.
And, really a picture's worth 1,000 words. I lean very, very hard on photography, whether it's anterior segment photography or meibography, either one of those. When you show someone their glands are missing, when you show them the telangiectasias at the lid margin, there's a different level of ownership that the patient has, and I think that's important. One of the tips that I've heard my friend and our colleague Paul Karpecki say, and you may have heard this from Dr. Karpecki at some point, he leans in and points at the photo and he says, I like to make the photo as big as I can. If you make it really big, it makes it even scarier. And I think that's true. He said, you make the photo big and you lean in and you say, there's something here that concerns me. And when you say that, if you were the patient and someone is looking at your MRI and they say, there's something here that concerns me, your heart skips a beat. you know, just those words. And I think that doctor concern is something that the patients are going to latch on to. And I think, again, photography and how you present that photography. And don't be like, oh, well, we see some of this and some of that, and that might one day be like this. Just say,
Right.
this concerns me that we're seeing gland loss here. You're so young. We want you to have good vision and good comfort as long as you can for the rest of your life. So we need to be proactive with that. Does that mean they're all going to bite? Absolutely not. And what we need to do in terms of being an optometrist and ophthalmologist is consider the fact that someone doesn't buy into what you're saying right then is okay. They may buy in next year. No is not a never. So we need to just be educators to our patients that also when they start to become more symptomatic, they do what? They come back to you and they don't come looking for me or Scott.
No, I think you hit it on the head. I use photos all the time to show patients what I'm seeing that gives me pause and it makes me want to engage with them. I think ultimately what we need to do is keep in mind that we're trying to advocate for the patient, right? And we're trying to give them guidance to have them take better care of their eyes down the road. And yeah, Whitney, you're exactly right. And they may not totally buy into it at that point if they're really not really feeling it, and maybe the visual fluctuations aren't enough for them to really give them concern. At least we've engaged them. We've documented what our findings were. We've talked to them about it. We see them in follow-up and say, how have these things changed for you? How are you doing? I think then we're working on building that partnership with the patient, and they know that we at least have things that we're monitoring with them and advocating for them down the road. So showing them pictures, making sure that we engage them, I think are the two biggest things at the beginning.
Other things that I'll suggest, in addition to the photos, would be some fairly easy proactive measures, like, hey, let's make sure all your makeup comes off. If it's a guy who maybe doesn't really have like a face care routine, then maybe I'll just say like, hey, after you brush your teeth, go ahead and use this lid wash. Things that maybe don't make them feel abnormal or that they have a hardcore diagnosis, but that, just recommending to them some things that can make things easier, switching contact lens solutions, switching into daily disposables. Those are things that can be just a little bit more proactive to keep them from tipping over into that stage 3 or having symptoms.
Does anybody offer cosmetics out of their office?
We do.
Do you have any favorite brands?
We, out of the chair, sometimes if I don't have it, Beauty Counter is a good one. It's pretty clean as far as ingredients. But another one that we carry the mascara and eyeliner for Lily Lolo. Again, no financial things here, sorry. Maybe shouldn't talk about those specific brands, but they're just clean products. And there's a lot of resources online when it comes to, if you just search, clean cosmetics, vegan cosmetics. There's tons of good brands out there, or tons of good brands that have that list all of the ingredients, no matter the amount or concentration, so that you can search for those hidden offenders that Laura Perryman likes to, are they the hidden offenders, or she likes to call them the hot offenders or something like that, where they can affect the ocular surface.
And also the We Love Eyes products as well.
I have a really quick little card, what do they call them, table card, that I give patients, just like kind of with the list you mentioned from Laura Perryman. I just condensed it over the years and saying just make sure you're doing these things, and with a little quick blip on there that hypoallergenic and organic don't really mean anything, because that's a big one. People say, oh, well, I'm using it and it's organic. And I pull it up on the Think Dirty or the EWG app, and I'm like, it's not organic. So this dirt has one organic product in it, therefore it can be labeled organic, and it has all this other stuff in it. So I've had that. I've had a patient that was so severe on rosacea that he could no longer wear his contacts. And I asked him what he was using, and I won't mention the product. His wife had gotten him something for the acne, really popular. And as Laurel Sulface, I'm like, just go off of that for 2 weeks and see what happens. And he came back, he's like, oh, totally fine. So listing a couple of the really common ones, I found I give them that little card on the way out, and they kind of make the choices.
Awesome. Thank you very much. All right, so we'll kind of, I'm going to move on. I want to thank you guys for coming up here, and again, for your awesome expertise and all of your clinical pearls, so thank you.